Okay, guys, nice to meet you electronically. I'm trying to focus on all the boxes. My name is Sarah Jackson. I work at Harborview. I'm a primary care doc in the adult medicine clinic and the medical director there. And John Geyer is also going to join us. It sounds like he has a COVID emergency at the VA. So we are, how we typically do this is we sort of tag team, and he does the VA part and I do the UW part. And so hopefully he'll be back. I think you may have met him already or will meet him because he does all the telehealth stuff at the VA. And I recognize some of these faces from Harborview. And I think, yeah. One of the things so this talk is about eConsults. Basically, the first part is kind of an infomercial for what eConsults are at UW and at the VA. And I do this just because I do a little bit of my time is doing QI for the UW eConsult program. And then really the bulk of it is actually some cases that our e-consultants have put together. They do these co-management conferences where they scan through their e-consults and pick ones that have good teaching points. And so we sort of cherry picked from their ones that they liked, and we'll go through some of those for you just as sort of a potpourri of bread and butter primary care stuff that they've seen. So yeah, and I think with that, I'll also just ask you guys, how many of you came from the UW for medical school from within the system? Great. Have you guys used eConsults in medical school? Great. So this will be familiar. And then for folks that came from outside, did your programs have eConsults there or electronic? Okay, yeah. So if at any point you want to kind of compare and contrast, or you have thoughts about your experiences, feel free to just volunteer those. This is super informal. So I will now share my screen. And everything disappeared. Great. So can you guys see the slides? Okay, thank you for that. I'll see if I can make this big too so I can see any chat boxes. Okay, so the theme of this is that eConsults are great. They're super helpful. That's sort of the big take-home message. And then I also want to just acknowledge the docs who actually prepared the cases. There's our dermatologist, Nick Compton, cardiologist, Ted Gibbons, and Tracy Tiley's the endocrinologist. And we'll go through some of their cases. And I think the point of this is to make you all aware of them so that you use them and give you some tips about what a good eConsult is, and to sort of go over the perks for patients, providers, and the big picture. And then we'll go through some clinical scenarios. And this is the overarching concept, is that the old school way to think about referring to a specialist is where you send them and they have to drive in their car to a time that's weeks to months out and miss work and have a formal referred consult with the specialist. The idea behind the eConsult is that if it's a simple question, one that you think that a specialist can very easily just look in the chart and see what's there and send you a message back, that is a good question for an eConsult. And I think thinking of them as like we used to think about curbside consults, where you would just run something by someone, or something that's sort of an algorithmic guideline type question. That's really what the eConsult question is supposed to be like. And at UW, we've been doing this since 2016. They're primarily for adults, except for dermatology and allergy, so you do some kid stuff. And we have 13 13 specialties that are on board. This is sort of the timeline that they've come on board. And it's been super popular. PCPs love it. They've done a bazillion of them. And you really do get the stuff back in 3 business days. So it's very convenient. And I mentioned the co-management conferences. Those are nice opportunities for specialists and primary care folks to dialogue about the work that they do. So it's sort of a team building concept for the university. And they're just FYI, they're working on a pilot with Capital Medical to take eConsults from outside of UW. And then, of course, I don't know if John is here. Let's see if we've got him yet. Let's make this really teeny. At the VA, of course, they've been doing this for a lot longer, and it's totally integrated into their system. Basically, any consult that is placed, I think they determine if it is going to be answered electronically or by an in-person visit. And they've been doing it since the early 2000s. You can see that there's a publication about PCP satisfaction with it in the VA system, the larger VA system. And they do synchronous video consultation with the specialists while the patient is in the room with the PCP. The patient can be at home or at a remote site and do the synchronous video visit. So they are much more advanced in implementing this at the VA in a sort of capitated system. And this is their list. We had 13 at UW. This is all the folks at the VA. There are a lot of them. It's essentially everything. And so this is just to review. The good kinds of questions for eConsults are generally focused ones that they don't need to do a detailed physical exam or take a detailed history. They're just using what's in the electronic record. We do at the UW prefer that if the patient has a specialist, that you work within their care team and not send an eConsult, just because there's somebody out there that already knows them and knows what's going on with them. So just being aware of that and not sending eConsults if they already have a rheumatologist who knows them. And then this is another sort of just big picture thing. eConsults really aren't for asking, can you get this patient in really quickly? I think they're very sick. It's not that. It's not for asking logistics about how do I get this ordered efficiently. It's not for asking about, what do you want me to order before you see the patient. So those are all things that in the UW system, it's best to ask of call the consultant who's on call and have that be a direct, rapid back and forth about the patient. And patients established in the specialty, I think I talked about that. And they shouldn't be things that you could just quickly look at up to date. And yeah, so we do QI on these, and often the people do, it's very tempting to ask logistical questions of the eConsultants, but really try not to do that. And then I think the feedback we get from the specialists the most is they can't really tell what the question is. And it's interesting, sometimes people really are very short when they send eConsults. So if you want a good answer, ask a good question, ask exactly what you want to know. So this is for UW, and essentially it's similar at the VA, except that it's okay to, if they're already engaged in specialty care, the VA is fine with you sending an eConsult. You can ask logistic questions, and you can ask them, if I'm gonna prep this patient for you, what do you want me to order? So those are some subtleties just to kind of keep in the back of your mind. Basically, the VA is all about doing things electronically and is very set up for it. So, Okay, I think that's it. And I'm just going to stop for a minute and just say, for folks that have used it, any comments, or and I'm also kind of looking to see if John is back from his, I think he had a COVID emergency. This will get bigger. There we go. Okay. Whitney, will you let me know if you see that John is back?
Absolutely.
Okay, thanks. Okay, so so eConsults are great. Take home message. Another piece at the UW, of course, the VA, you don't have to worry about this, but at UW, specialists can bill for eConsults. So as a part of that, it's important to tell the patient that you're getting one. Let them know that they're getting this service. There's a button you have to click when you place the order that says you consented them for it. So do that. It's tempting after the patient is gone to be like, oh, this would be really nice to ask of somebody. But if you do that, just make sure the patient knows that you're getting an eConsult. And then when you get the results back, it's really nice to tell them what the consultant did, recommended, so that they are in the loop and know that they received this service and got that information. Yeah, and I think really one of the huge perks of the eConsult programs are they help primary care and specialty folks to work as a team. It just encourages better collaboration and less siloing of specialists and PCPs. It's fast. That's one of the awesome things about it. And it can keep people from having to do all the things I mentioned, like taking off time from work, getting childcare, parking, the expense of all of that. It's a real service to patients and to the system. It decreases costs. And then I'll just quickly go through this because you were not going to remember it until you're doing it, or you may have already used it. So this is what it looks like at UW if you put in an eConsult. Each specialty has their own template, and you have to kind of F2 or skip through and add the information. The specialists have put that stuff in there because those are the things that help them to answer the questions. So, and then in most clinics, I think our medical assistants upload the pictures. This is Derm. Derm is our biggest eConsult group at UW. But if you needed it, this is how you would do it. And I'll just mention Haiku. Do you all have Haiku on your phones? Anybody got? Okay, so you guys are all ready to go. So if you take the picture with Haiku, you don't have to worry about the HIPAA stuff of having the photos on your phones. And this can be uploaded straight for the eConsults. So that's great. And then this is what it looks like. It comes back into your eConsult folder in your in basket. And you just, there's a standardized template for response, and you can just act on whatever recommendations you think are helpful. And then this is the view at the VA. You can see the many, many eConsults that there are. Hey, John. Oh,
hello.
great. Yeah, perfect. Yeah. I've just been kind of, hopefully I'm not misrepresenting what happens at the VA.
Hopefully not.
I think, yeah. And I was, yeah, just saying.
Yeah, go ahead.
Go for it. And actually, if you want to just introduce yourself too.
Yeah, John Geyer, one of the primary care doctors at the VA, and I run our primary care telehealth program. So yep, you can non-visit consult any service at the VA, which is great. And for those of you who don't have your primary care continuity clinic here, a lot of the rotations here, you get experience processing, if you do a specialty rotation, processing these consults on the other end. So you'll encounter them one way or the other. Endocrine rotation does a lot of e-visit consults. And so definitely we'll get some experience with that if you're on that rotation this year. And there's maybe one or two of the eConsults that have a template, but most of them are open text. The more specific you are with your question, the better. If you are the specialty service that's receiving the consults, and you get a a generic question or something like that, obviously it makes it really hard to figure out what the provider is asking for and to formulate a good response.
Okay, and then this is just FYI. These are the folks that are the eConsults sort of admin team at UW. So if anything comes up or around eConsults, these are faces and names to just be aware of. And I think with that, sorry, John, I basically the take-home message for the VA was that you guys have it extensively available and for pretty much all scenarios. Yep. Okay. And we're going to transition now to just doing some cases. And these are cases that, as I mentioned, the cardiologists and the dermatologists have sort of highlighted as ones that were interesting. And we'll start with this one. This is a 35-year-old guy who presented to clinic with atypical non-exertional chest pain. I suspect that the cardiologist changed the stem of this, but anyway, atypical non-exertional chest pain. And they did a 12 lead in clinic, and it read back the automated part, said lateral infarct. And I guess it might be good to just start with, does anybody want to sort of volunteer the 3 components of typical chest pain, either by chat or if you want to just talk, that's fine too, or any of them.
Is it present with exertion? Is it relieved with rest? Oh God, I can't remember the third part.
No, that's awesome. It's funny because I do this and I still have to just make sure that but it's substernal chest pain is the other one. Yeah, you got the 2 harder ones. So yeah, stress and exertion, and then is relieved by rest or nitroglycerin. Those are 2, and then substernal chest pain. So he had 2 of the 3, and he's telling you that it was not exertional. So probably, and then non-cardiac chest pain would be one of the 3. So, and then here.
Does it mean the EKG read is like the read from the computer, or like we are reading it as?
That's exactly right. Yeah, thanks. It's what it spits out at the bottom of the EKG. It says lateral infarct. And so this is the EKG that they're looking at in clinic. And if, anybody wants to sort of kind of take a minute and look at it and tell me why you think it's saying lateral infarct. And maybe if you want to start with which leads you're looking at when you're thinking about lateral changes.
T-wave inversions in lead 1 AVL.
Great. And then what do you think, how does that, any other thoughts about this besides those T-wave inversions and kind of cues in 1 and AVL? What other leads do you look out for lateral changes? Anybody? I usually think about, and jump in if you're, but I look at V5 and V6 are my other lateral leads. And what do you think about those compared to the limb leads? You see changes of infarct there?
Maybe some Q waves?
Maybe tiny Q waves. Yeah, possibly, maybe. So those are, 1 and AVL is what that computer is using to call as infarct. And this is interesting. Yeah, any thoughts about this? This is, and I'll just add to that this is a 34-year-old guy or 35-year-old guy with no diabetes, no hypertension, no smoking, no lipid changes, no early family history. He has no risk factors for heart disease except none. And he's having this atypical chest pain, and this is the EKG. So just any thoughts about that? This is kind of a trick question, but it's an interesting one, I think. because you are, I think we talk a lot about pretest probability for heart disease, and this is actually, this patient had their limb leads reversed in clinic so that 1 and AVL were switched, and that's why you see the change in the polarization on those leads. So this is totally an artifact of incorrectly performed EKG, which the cardiologist was able to tell the PCP on the eConsult. So just something to, I think this is a great teaching case, mostly because, especially for interns, because when you're getting data back that doesn't fit your clinical, what you think is going on clinically, sometimes it is good to just step back and say, is this piece of data actually accurate? Or do I need to repeat it or look and see how it was done? And this is like perfect for things like a K of 6 that might have been a hemolyzed sample, or a really low PO2 that's not really an ABG but a venous blood gas. So that I think is the teaching point here. And then just to throw in, this is the chart that looks at typical, atypical, and non-anginal chest pain by sex and age. And the range there, you can see at one end, those are folks that have 0 risk factors. I think they're looking specifically at diabetes, smoking, and hyperlipidemia. So you can kind of eyeball your pretest probability for someone. And this guy was 35, atypical angina, no risk factors, so 8% likelihood of CAD. So just something to keep in your framework as you're evaluating folks. Questions about that or other thoughts? And then 60-year-old woman. So this is another common, super common thing that you see in primary care. 60-year-old woman who has really well-controlled diabetes, hypertension, and she actually came into clinic feeling totally fine, and the MA noticed an irregular pulse. This is actually my patient. She's lovely and is super well controlled. Her chronic conditions, not because of me, because of her. And this is the EKG that they got in clinic, and you can see those asymptomatic PVCs, the wide complex is there. And you can see on the rhythm strip at the bottom, they're pretty frequent. So any thoughts about, like, this was actually a resident that saw the patient. What would you do for her next? What are your thoughts? You can chat it, or if you want to just talk, that's great. And I think in there is, do you need to do anything? Is this something that she feels totally fine and this just happened to show up? Is there anything else that you got to do or think about? See if there's any chat. Let's see.
Has anybody received pages when you're on service for PVCs for a patient that's on tele? Those are always really fun to know how to deal with.
Yeah, it's super, super frequent. Any thoughts, any lab work you'd want to do? Or how many people vote for not really doing anything? She feels fine, don't really need to do anything. I think this is what I would have done, honestly, with my patient, is I might have said, yeah, no big deal. Yeah, but the residents, if you were to order something or anything you would order, feel free to just talk. Let's say lab work, any lab work, if someone's having a lot of PVCs.
Electrolytes.
Great, yeah, electrolytes would be great. Anything else? Or any tests you would order if you really, let's say she was symptomatic, any tests you would order?
If you wanted to quantify like the burden of her PVCs and see if it correlates with her symptoms, you could do like a 2-week Holter monitor, have her diary her symptoms, and then you got a lot of data.
Yeah, that's great. Yeah, and I like I just mentioned, I don't know that I would have necessarily done anything, but the resident that saw this patient did get electrolytes, got a TSH, which is another thing you could think about checking on. They were hyperthyroid, and they got a Holter. And the Holter came back with PACs, no SVT, but they had 8% PVCs, and there were 12 runs of non-sustained VT. The longest was 8 beats at 142. And she felt fine. She didn't put anything into the monitor diary. So you get this back, and I guess the next question is, now that you've got it, what are you going to do with it? Would anybody, any thoughts about that?
I'll just reassure her and tell her everything looked normal.
Yeah, that's I think what I would have done too. This was a really interesting eConsult for me. Yeah, she does have, yeah, so anybody that would do anything else? More workup?
I'd place an eConsult.
Yeah, place an eConsult. Yeah, and this is the perfect point of this, is like if it's just in that thing, you're not really worried about the patient, but you kind of have this nagging question of, should I do anything else? eConsult is great. And this is what the Holter looked like. That's her in SVT. And so the eConsult comes back, and you can see that he gives information. He's looking at the configuration of the PVCs. He's looking at the fusion beats and the NSVT attributes of those. And he actually, the cardiologist, recommended a stress echo and to come to cardiology after completing it. And his rationale, this is all included in the sort of templated feedback, is that because she has the risk factors of diabetes and hypertension, she's in her 60s, it sounds like on the factors, the morphologic factors of the PVCs, that it merited further workup. So I think that was a learning piece for me. And one of his, and that also some of the data helps them to decide whether how likely a beta blockade or calcium channel blocker will be useful in helping with the PVCs. So some of the things that they think about are the PVC symptomatic or asymptomatic, density complexity, thinking about metabolic derangement, calcium mag, thyroid, structural heart disease, looking at the morphology. And this says complex or frequent PVCs greater than 10%. Hers was 8%. So I think this is still in the borderline here, but it was definitely a learning eConsult for me. Okay, questions or other thoughts about that? Okay, and then this next case, we're switching gears and we're gonna go to dermatology. This is a guy, a 52-year-old guy who presented with the rash. He actually presented at Pioneer Square, which is our clinic that sees homeless patients. He'd had it for a year, not itchy, not painful. He had untreated HIV that was, he'd known about for a while. And somebody at some point had thought about Kaposi sarcoma in the past. Arms, hands, legs, and this is just what the eConsult looks like in there. It looks like he also had tried tea tree oil, but that is really the information that the dermatologist had to make this eConsult recommendation from. And I'm going to show you some of these pictures, and as you're looking at them, maybe be thinking about, so untreated HIV, homeless, patient, what other information do you want to know? And what are some of those good descriptive dermatology type words that you would use to describe this rash? So this is his forearms. I think that's closer on the forearm. And there's his hand. Yeah, so feel free to just yell out via Zoom any descriptive words or other information that you want to know about this guy.
I feel like they look like a lot of like circular erythematous lesions of varying size, with some like some central clearing, and then like a scaly, crusty border.
Awesome. Yeah. Scale, circular, annular. Yep. Anybody want to mention some of the things that you might want to know historically about him besides the untreated HIV, or if he was sitting in front of you?
Has he ever had fungal infections before, like tinea?
Yeah, that's a great question. Yeah. And I don't think we know from the eConsult or the chart, but that's a great question. Yeah. Because tinea would certainly be nice and circular like this with scale. Other thoughts? There's kind of an enormous differential here, so feel free to shout anything.
Well, I just think that with this case too, we don't know his immune status, and things can present very strangely if, even if they're common, if you don't have an intact immune system.
Right, and they did not have labs. That's another piece, is they didn't know what his HIV, his quant was, or any of that. So, okay, and I know, John, I don't want to short your thing, so I'm going to keep moving. But and then I'll just mention the photo tips. He spent a lot of time on this, so I will just give it a little bit of play. But if you are taking the pictures on your haiku on your phone, it really helps them to see where it is on the body. If you're taking the picture of something small, put a landmark in it, and then do a regional, medium, and up close. Other things, put the patient's label in the picture so they know who it is. If you have a blue marker, circle it. Blue chucks behind the skin is really helpful. Force flash it. The camera perpendicular to the skin. Focus in the middle on what you want them to look at, and then check the quality. Make sure, because this was his whole point in this. One of his biggest points in the conference was this is how they make their recommendation, is on the photos. So make sure you send them good pictures.
And I don't know, Sarah, if this has happened a lot for you, but of patients with dermatological concerns at home, and they'll send you pictures of their rashes in your eConsult portal, but those recommendations I think are helpful for patients to be self-taking photos as well.
That's really true. And they're doing more of that, of course, with COVID and telehealth directly too. So yes, those are great tips for your patients. Okay, so I won't spend too much time. Like I mentioned, this is a long potential list, but what are things that are at the top of your list? And you can type this into the chat too if that's easier than the Zoom. What are you thinking about? And John, for some reason, I still can't see my chat. So if you see.
We got psoriasis.
Yeah.
Disseminated cocci, fungal.
Awesome. Yep. Any other infectious things that you're thinking about in a guy with untreated HIV? Totally looks like psoriasis. I like the fungal, atypical mycobacterial.
Cutaneous lymphoma, that's a good one.
Oh, that's a great one. Yep. Yeah, there's one I'm kind of hoping you guys come up with. So yeah, think a little bit for another second or two. HIV positive, homeless guy, a rash. You might have gotten, you might even have asked some history about this when you were seeing them.
Great, we've got Kaposi sarcoma, seborrheic dermatitis, scabies, and syphilis.
Woo! Okay, great. Yeah, those are great. Great thinking. Yeah, so this is, his words were serpiginous, annular, polycyclic, scaly plaques with scar. And at the top of his differential was secondary or tertiary syphilis. Second was subacute or discoid cutaneous lupus. Another one that's sort of out of the box. And then partially treated psoriasis, atypical mycobacterial infection, and tinea. And what are your next steps? I think I'm going to skip that because I know oh, sorry, John.
Oh, no worries.
So papulosis eruption and HIV. So other questions, the sexual history of syphilis in the past, a chancre or treatment are really things, I think this is the take home is, do be thinking about syphilis with HIV. Photosensitivity is something else he would ask about. Of course, we want to know this. You could have KOH'd it, and then checking the syphilis serology, and then a skin biopsy. And this patient, actually, they did the eConsult, but they weren't able to get any labs. This is the actual clinical course for this guy. So he went back, they got the eConsult back and weren't able to get a hold of him to do any of this stuff, which I think is another piece is trying to get labs when you can from patients that may not come back. And then what actually happened was that he came back to Harborview with a headache and a fever. And he was hospitalized with bacteremia. His RPR was positive, super positive. And then they did a lumbar puncture, which was also positive. And he was treated for 2 weeks with PNG, and his rash got better. But of note, he also had a history of psoriasis that came up when he was hospitalized. So you can have two sort of things going on at the same time. Okay. And yeah, I think we talked about that. Okay, and now I'm going to turn it over to you, John. Sorry.
No worries. We'll breeze through this because I want to make sure you guys get a break. But go ahead, next slide. So eConsults are really common in endocrine. A lot of them have to do with thyroid nodules or hypo or hyperthyroid states. Next slide. So eConsult 1, 80-year-old woman with thyroid nodules incidentally found on a CT. You may posit the question, does that patient need a thyroid biopsy? Everyone, and the response yeah, go ahead. The response, we'll just move on from this, is please obtain a thyroid ultrasound and TSH, enter additional consult when results are returned. So sometimes in eConsults, the consultant will ask for additional data points if they don't have it and can't sufficiently answer their question at that time. Next slide. So the reason why they're asking for additional imaging is because the risk of malignancy is pretty low for thyroid nodules that are incidentally found on CT. And the malignant potential is determined based off of the morphologic features from ultrasound. So it's the size, and then what does it look like, density, that sort of thing. And the criteria, if you're going to do a biopsy, is based off of the morphology and the size of the nodule. And then there's different guidelines. Both UW and the VA use the ATA guidelines. For both radiology reports that you get back from ultrasound, they'll include the guidelines that the radiologist will use. They won't necessarily recommend if a biopsy is necessary. They'll just give you that information. And you can see that there's a lot of nuance. Is it solid nodules, the size, mixed cystic or solid? And sometimes the radiology report will have those specific terms. Sometimes it won't. They'll just say there's increased echogenicity or something generic like that. That doesn't really help you decide. Next slide. And there's the high suspicion, low suspicion. These are the ATA guidelines, and you can see if it's big and a lot of complexity, then it's probably gonna get biopsied. If it's small and doesn't have a lot of the suspicious features, then it's probably not gonna be a recommendation for biopsy. And does anybody know why the endocrinologist wanted the TSH? Why would you get a TSH if you have suspicious thyroid nodules? Any sense to that? Hot versus cold, perfect. All right, so next slide. So the TSH can really help determine, do you even need a biopsy? Because in Hashimoto's or with thyroiditis, they can have some of those morphologic features that look like you should biopsy, but you really don't need to, because once you get the TSH, you can consider other things on your differential. All right, so back to eConsult number 1, you get that ultrasound report, the TSH is normal, but there's your radiological description, spongiform, cystic, solid, TSH, again, normal. Would you guys trust your own interpretation of the ultrasound report, or do you feel like you would send an eConsult to endocrine again? Raise your hand if you would eConsult. Okay, yeah. So I would say this is a great case for an eConsult, just because there's nuance, and something like determining if you're going to get a biopsy or not, that could be that could change the direction of care, is something that it'd be helpful to get more input on. So next slide. So and that's just highlighting again what comes with the radiology report. So here's your eConsult question example. So stating patient is clinically well, so it gives them some context. TSH is normal. Ultrasound results now available. Does patient need FNA? So that gives the eConsultant enough data that they can answer that successfully. Next slide. No biopsy needed. Nodules are considered low risk. Hooray. Next slide. So eConsult number 2, I think we're almost out of time. So why don't we just skip to the end?
And John, we did start 7 minutes late too. So
oh, okay.
It'd be great if we could catch up too, but yeah, that's fine.
Let's see, just highlights from this particular case is that nodule noted in 2016, and then you re-imaged it, which will happen sometimes. Most recent nodule shows a larger nodule, but pretty much unchanged. TSH is normal. So your question in this case is the patient clinically well? TSH is normal based on imaging and guideline review. I don't think needs a biopsy, but how should this nodule be followed long term? So you might not need a biopsy, but question sort of surveillance for nodules. And again, this is an example of a good case for an eConsult, because the guidelines for surveillance they change a lot. There's open for interpretation, and really is something that a specialist should provide input on. Next slide. So there's nodules that don't need FNA criteria if they're low suspicion, but they may need some sort of follow-up imaging. So if it's sort of this mid-category of intermediate suspicion, doesn't meet the criteria for biopsy, but you may want to repeat the ultrasound. And so that nuance, I think, is really helpful to have the specialist weigh in on. Next slide. So this is actually the response from this case. You can see it's more complicated. Stable on imaging for 2 to 3 years, then no further imaging is needed. Would recommend a follow-up ultrasound if patient develops new compressive syndromes, neck pain, pressure, feels the nodule is increasing in size, or if the nodule appears larger on physical exam. So does require some follow-up and some pretty specific guidelines of symptoms that might change the picture. Okay. So you repeat the ultrasound in 1 year, you review guidelines and note that now meets criteria for an FNA, you place an order for the procedure, results return normal from the FNA, no concern of malignancy. So the last case point, next slide, you put in an eConsult, so now you've got a normal FNA on a nodule, what surveillance is appropriate in that setting, and again, another case where you could eConsult to answer that surveillance question. And there's another guideline set that's open for interpretation. So takeaway points for the eConsult for endocrine cases, if evaluation of nodules to determine if an FNA is needed, and thinking about how to plan for long-term follow-up of previously benign nodule. They will sometimes switch to in-person consults from endocrine perspective if it's a high-risk nodule in ultrasound, or if there's an evaluation of a nodule with suppressed TSH, and then they want to see anybody that has a nodule that's been previously biopsied with a result that was anything but benign. And so being specific in your eConsult, try if it's something that you can answer from reviewing the guidelines and you feel confident in that, then that's a fine process. But if there's any nuance in the guidelines and you want somebody to help you sort through and give some clinical direction, then it's good to use an eConsult for thyroid nodules.
I do think thyroid nodules are the perfect eConsult
Yep.
because they change those guidelines minusculely a little bit. And, yeah.
Yep.
So great. Okay, so well, we did pretty well. We've got
Yeah.
we've got more time left than last. Yeah, so big picture, just remember to place eConsults. Think about them as it's an opportunity as a learning tool, if nothing else. Yeah, it's fast responses and good for patients. Good for you, good for space, save space in the specialty clinics for the really sick folks that really need to be there. And I think clinical pearls, number one, if your clinical scenario doesn't match the data that you're getting back, it's good to go back to brass tacks and think about whether your data is really accurate. Use your gut when you're thinking about things like that. Second, HIV, rash, syphilis, try to group those together in your mind and always consider that. And then I think PVCs, thyroid nodules, these are really great types of topics for eConsults. So I look forward to working with all of you, and thanks for your attention. Questions or comments? Okay. Great. Well, enjoy your few minutes here between now and the next Zoom thing.
Thank you.
Bye.
See you guys.
Thank you.
Thanks so much, Sarah.
No, thank you, Whitney. Appreciate it.
Yeah.